Thank you, Mort. It's a pleasure to be here. I think I'm the only speaker from Boston, and PK spoke about the election, so I just have to give you our view of it. We have Erling here from Denmark and from friends from many countries. So here's what we think. Boston had a choice. We had a presidential candidate, John Kerry, and we had a baseball team that had never won the World Series in 86 years. And the word was that there was a curse on our baseball team that we could never beat the Yankees. And apparently a group of citizens had some discussions about this choice, and you saw the outcome. So that's part of it. The second thing we've noticed in Boston is that people in the United States who are in the political minority all live on the coasts. And so that seems to be a risk factor for being somewhat out of it politically. And John Stewart on the Daily Show noticed this, and he said they're working on mechanism, and they think it could be boats that are causing this. Okay, so that's what we have from Boston. I'm going to speak about vulnerable plaque, and before Jay calls me a Luddite who's back in primitive age thinking about vulnerable plaques and I should be thinking about endothelial dysfunction, I want to remind Jay that you spent a lot of time even farther downstream in heart failure, right? I mean, we're at least farther up from the field that you led.
I got smart.
Yeah, but you've gone so far back. So we're not there yet. So we're kind of near the end of the process trying to find vulnerable plaque. And the patients that we are working on, of course, are going to be the ACS patients, acute coronary syndromes, and stable angina patients who find their way into a cath lab. And I will say, Jay, that no matter how many Rasmussen scores you give people, they're going to, I think you'll agree that there are patients who will never come to your center, who will smoke cigarettes, who will eat whatever they want, and no matter how much we know, medicine's going to have this constant flow of patients, right? So we have that flow to deal with, and maybe half the events come out of that currently, and will continue to. So I would say while this screening, starting with the general population, doing blood tests, testing we've talked about, is critical for first events, there'll be basically two flows of patients, some coming this way and some coming this way. I have not worked in this area. I want to congratulate the people who have been working in this area, particularly with Dr. Hecht and many others who persevered with the calcium scoring and showing what a marvelous predictor it is of risk, much more powerful predictor than the ones that we've been using. But I think that the vulnerability detection in the cath lab will be helpful to screening, and I'll show you a couple reasons why. This is from John, who put this in the SHAPE documents, and he pointed out that when you do this non-invasive screening, sometimes you get on a very interesting train because you find some calcium, but then you also find what's called soft plaque. And I know there was a patient from Krakow, I think, that Dr. Dudek and his colleagues found where the patient was in the cath lab, had a left main stenosis, and there was an indication it might be a soft plaque by virtual histology, by ultrasound, and a stent was put in a stenotic lesion, but not real tight lesion, because it might have been vulnerable. So that's going to happen in the cath lab. It will happen as more and more EBCTs and 64-slice multi-detectors are done. There'll be these questions come up. What about these lesions? So there will be kind of a flow, I think, of patients who will end up in a cath lab with someone trying to answer the question, is this a dangerous lesion? Now, I must say I read this that John wrote and agree completely with him. It said, although it's much discussed on soft versus hard plaque, the characterization of any soft plaque as one that is potentially vulnerable remains moot. And I go a little further and say it's even dangerous to call them soft plaques. They should probably be called low Hounsfield unit plaques because we really don't know whether they're soft or hard, and we certainly don't know what their outcome is going to be. What is being assumed, of course, is that these are plaques like this. These are cross-sections of coronary arteries at autopsy from 6 patients that have these lipid-rich pools that maybe you can see eventually, non-invasively, and they go on to disrupted plaques that look like this. There's been a lot of debate about how many plaques people carry around like this, and we had done a study with this company I founded that, just by way of disclosure, it's building a near-infrared spectroscopy catheter for coronary plaque detection. But this company examined 50 hearts at autopsy. They were coming from a supply house, so we don't have all the data we need, but about half these patients died of cardiac disease, about half didn't. 32 of these hearts had no thin-capped fibroathromas or disrupted plaques. These are probably people who died of cancer. Here's 4 of them had 1 TICFA. Here's a patient that had 5 thin-capped fibroathromas and 3 disrupted plaques at the time of autopsy. So these things are, I would say they're frequent. They're not everywhere within the coronaries, and they're not so frequent that they would be too hard to find or treat. It's just a graphic demonstration of the same data. So what can you do? What could the cath lab person tell you today if you wanted to look at that possible soft plaque question? Could they find if it was a plaque that had a lipid pool? What tools are available? So I'll run through these quickly. There's angioscopy, and Dr. Mizuno and others have pioneered this work, and there actually are follow-up studies with angioscopy showing that yellow plaques produce events. The difficulty with angioscopy is you have to occlude the blood flow. But there's IVUS, and there are wonderful new studies going on to expand the use of the IVUS signal with virtual histology and elastography, both of which are presented at these meetings. There's optical coherence tomography, near-infrared spectroscopy, temperature, intravascular MR, and nuclear methods, the least developed. So here are all this vast array, and Jay would say to me, why are you doing this to people? You should just change their lifestyle earlier. And I would say this, that there'll always be this flow into the cath lab. And secondly, this field of refinement of tissue properties and predictability of who's going to have an event might go through a cath lab phase, where the cath lab is a science laboratory where these questions of can you find this kind of plaque and does that predict trouble are first approached. And it would also, I think at some point, once you can find these in the cath lab, then you have a gold standard for finding them non-invasively. This shows what's being done with the by Volcano with the ultrasound signal, and they're looking at the reflection of sound, not just amplitude but phase information, and that permits them to gain added information about tissue. And this is being evaluated now prospectively in multiple studies. Here are the goals. They want to use IVUS because it's easy to use. They want to improve the consistency of the image interpretation and learn more about what you can find out about the composition of plaque. These are catheter pullbacks showing reproducibility. Now, you probably also all heard that during changes in intraarterial pressure, the wall moves if it's soft. So this is the basis of palpography, with Dr. Shar has pioneered from Rotterdam. And they've actually now found a number of patients with acute coronary syndromes that have plaques that appear to be soft, and that's more frequent than in the people that are stable. Temperature you've all heard about. There's no doubt that the plaques that are inflamed are hotter when they're on the table. There are problems measuring that temperature increase in the presence of flowing blood, and there's studies underway to try and cope with that complication. This is optical coherence tomography, which is this is the Mass General group. There's another group with Light Lab. Basically, this is the optical equivalent of IVUS. This is a study in a living patient. Requires a blood-free field. Patient had an infarct. There's a rupture here and a rupture here. This is a thrombus. This is lipid pools. And they have a publication now showing that macrophages have a distinct OCT pattern. The difficulty with this technique, it requires the blood coming out of the lumen. This is the approach of topspin, which has, amazingly enough, taken an entire MRI machine and put it on a catheter tip, magnet, coil, and all RF signal detectors. And they're now in patients, and they can show that if they get this yellow signal from lipid pools, MR, of course, is very good at detecting lipid. The difficulty with this method is the catheter has to be up against the wall. It takes 40 seconds to get the measurement, and it cannot scan the artery. But it could certainly tell you whether there's lipid at that one spot. This is the approach our company has taken. It's using near-infrared spectroscopy, which is used to tell chemical composition of the moons of Saturn and other places. And it's highly developed technology, not used much in medicine, other than for O2 saturation devices. It turns out with laser, fiber optic, and chemometric advances, you can perform this in the human coronary. Catheter has been built. It's like an IVUS. It can scan through blood, takes the spectra very fast, and it can tell the chemical composition in vitro. Clinical studies will start in March. Now, all these techniques need this kind of a study, some kind of natural history study. Take 1,000 patients in the cath lab, put in the vulnerability detector, find the patients you think will have an event, check them up for, like the beautiful follow-up studies we've seen done for EBCT and others, follow them up for hard cardiac events and see if you can really find the 10% of patients here who are going to have events and separate them from the 90% that aren't. So the goal here would be relative risk of 60 or 70 rather than 3 or 20. To actually find the disease that is going to do it. And the question, of course, is there a biologic signal that strong or not? It's really not known. Now, I'm very happy to say that there are 2 natural history studies already started. This is funded by Guidant and Volcano. It's a 3-vessel imaging study. They do IVUS on all 3 vessels. Actually, the FDA suggested that they do all 3 vessels in patients. And they do virtual histology, palpography, and thermography in the European patients. They follow these patients up, and they do repeat imaging in patients with events. And, you know, given our focus tonight on non-invasive screening, it would be awfully nice if these patients, there'll be 600 or 700 of them, had a non-invasive test, and you could see if any of these sites that indeed turn out to cause events could be detected non-invasively. Or could the subgroup who have these positive intracoronary findings be identified non-invasively? That would be very nice to know. These are the endpoints on the prospect study. Now, the other study, which I don't have a slide of, is called the PREVAIL study. This is a newer study. It's being considered by Cordis. And this study, I know there's some interventionalists in the room, and most of my interventional friends tell me that the drug-eluting stents have made it more likely that a stenosis will be stented. So it used to be a 70% would get stented. Now a 50% might be stented. And then the question raises, well, if you're going to stent a 50% stenosis, how about a 45 or 40? Where's the line? And as that line moves down towards less stenosis, there is equipoise. There's an opportunity to randomize patients. And it would certainly be nicer to randomize patients if you had a vulnerability detector for those intermediate stenoses. So that's the PREVAIL study. It will be an intermediate stenosis drug-eluting stent study. But all of these studies, they're going to try and create something like this, where you measure something in the coronary, take something you think is a vulnerability map, follow patients up for events. And of course, the main suspect for a vulnerable plaque is a thin cap fibroatheroma that's inflamed, and people will build their devices to detect that histology. But it might be that there are other things that cause these events. So when you get the events, you'd have to look back and see if there were other baseline signals in your library that predicted risk.